We're on.
Hello, everyone, and I hope you're enjoying your COVID-19 summer. At least we have some weather that is cooperating, which makes things sort of livable because outside, obviously, there's much smaller chance of getting infected. Okay, let's talk about COVID, although we will talk about some more items as well. Vaccination. Yesterday, a big splash, at least in the media, about Pfizer's new vaccine. And there's a lot of optimism, of course, but when you take a look at the details, it's very preliminary. What they did find was that there was some antibody generated in people who got the vaccine, although they had to have basically 2 shots, a booster, in order to render enough antibodies. There were also side effects, fever, malaise, etc. But I think also important to understand that just because they detect antibodies doesn't mean that people will not get infected. For that, of course, time has to pass to see whether or not these people will get infected. So it's an interesting step, but there are many vaccines that get to this stage and then never go further. So, Jonathan, I know you've been looking into vaccines like you, of course, you always do. And there's some interesting stuff emerging there among how people perceive vaccines and how the anti-vax community bizarrely is energized by this whole business, and a large percentage of them saying they will not take a vaccine. They don't trust the vaccination studies. So I know that you've been looking into this, vaccination studies and how do you really do this and why are there placebos?
Yeah, I mean, and that is a common trope that we've been hearing from the anti-vaccination movement for a while, this idea that in all of the clinical trials of vaccines, never has a true placebo ever been used against the vaccine, which is absolutely not true. But it does get more complicated than just, when you have a new vaccine, you have to test it against a true placebo, which in this case would be an injection of saline, which is water with the same kind of salt content that you would find in your bodily fluids. There are situations where you should be doing that, but there are situations where you shouldn't. For example, if there is a vaccine that already exists and you're making a vaccine that is supposed to be better, that might protect you against more strains of the virus, to deprive your control group of this pre-existing vaccine would be seen as unethical. So you would usually use a pre-existing vaccine in the control arm. What's particularly interesting is that, so I've been looking into this issue of what kind of control do you use when you're doing a vaccine trial. And if we're looking at COVID-19, there is no vaccine right now, no approved vaccine for COVID-19. And so the idea is that if you are doing a clinical trial, especially a phase 3 clinical trial, which is the last phase before approval, this is where you're really looking at efficacy, right? Does this really immunize people against the disease, yes or no? The comparator should be a saline injection. But there is a trial that is ongoing in the United Kingdom right now that has been quite heavily promoted, where they're doing these combined phase 1, phase 2, and a combined phase 2, phase 3 trial. But they are not comparing it to saline. They are comparing it to a meningitis vaccine that already exists, that we know is safe and all that. So the question is, why are they not using a saline placebo? And the reason that is given by the people who are running the trial is the issue of blinding, which again goes to show just how complicated this whole issue is, which is that if you are receiving because in these trials you don't know what you're going to get, right? So you're randomized to 2 arms. Either you get the experimental vaccine or you get the control. And if you get an injection of saline, your arm may not be sore the next day, whereas it would be for a true vaccine. So there are these side effects that you would normally get that are very temporary with a vaccine injection. We've all had this. When I get the flu vaccine, my arm is quite stiff for about a day or two. But if you're not getting those symptoms, then the blinding kind of falls because you think to yourself, oh, maybe I must have gotten the placebo. And in the case, especially of COVID-19, the idea, what the researchers are saying, is that if we were to use a saline placebo, people might discover which arm that they're in, and that might alter their behavior. And so you end up with 2 arms that behave differently. Now, is that a good enough Explanation for why they're not using a saline injection, I don't know. Some people have said, don't know about this. And it will be interesting to see what the regulators have to say if they go forward and they submit this data for their vaccine to be approved, because they will not have tested this against a saline injection. All that to say that even though there are sort of recommendations that exist, researchers seem to be able to do whatever they feel is best for this particular situation. So it's not always as simple as we always going to compare the vaccine against a saline injection. So we'll have to see how all this pans out. This is the only vaccine that has made it thus far against COVID-19 that is not being compared to a saline injection. So we'll see.
Okay. You know how on TV shows you get to watch practically half the show until the credits come up or the title of the show comes up? I think
depends on the show, but yeah, it's being done quite a bit.
We fall into that trap here. We started out and I didn't mention who we are and why we are here. You're listening to Conversations with the McGill Office for Science and Society. And my colleagues, Jonathan, Jerry, and Emily Shore are online here.
That's what we did. We just did a cold open. We did a cold open. And now this is us.
All right. So now you know what it is that you're listening to. Yeah, just for a moment, back to the vaccine business. So much talk about, the research and placebo control, not placebo control. The fact is that we will not know whether a vaccine is truly effective until it is out there in the population at large. And that likely will take years. There'll be candidates. I mean, there already are. I think there's 178 vaccines now that are being researched. So we will have some. They will be on the market. But the fact is, we will not know for a long time which or if any are working.
It'll be interesting to see. It'll be interesting to see if those human challenges are eventually approved, because that would be a way of figuring this out. Now, those are very, very ethically fraught, because it's this idea that you are taking volunteers, you are injecting them with the vaccine, and then you are purposefully exposing them with their consent to the virus to see if they get infected, yes or no. So that's being discussed right now. Like, is this ethical? There are a bunch of people who have signed up for this in the hopes of speeding up development of vaccines, but it is ethically very ambiguous.
These are the people on the opposite spectrum who oppose the vaccines. These are people who are willingly... These people are
very gung-ho about vaccines. They're like, you know what, I'm young, I have no pre-existing health condition, I want to help. This will shorten the amount of time that it'll take for us to realize if a vaccine is truly effective. But even though a bunch of people have signed up, this is still being debated by ethicists, because, of course, there are major ethical considerations here.
I think that as time goes on, I mean, maybe, at the very beginning, everyone was like, okay, this vaccine has to happen. We need it to come. It's going to be this like magic bullet, this, something like a movie all of a sudden, and it's going to fix everyone. And the scientists were probably the only ones who were thinking, oh my gosh, vaccines take a long time and they know development. But as we've now like really gotten into this COVID routine, I feel just a layperson, and the people, who I am surround myself with, it's almost starting to sink in that this is not all of a sudden going to be a magic bullet, and one vaccine is going to be a cure-all, and this is going to be a long haul. And even me, I'm hoping that a vaccine will even be effective, because I know that there's been problems with the antibody testing and the diagnostic testing that almost makes me think that, it's a trial and error. It takes a long time to get things right now. Like, this is science. This is how science works.
There are so many questions about immunity, right? And we're seeing research showing that, those antibodies that we thought might be protective, well, they seem to be disappearing pretty quickly. And then other immunologists saying, well, actually, it's not just about antibodies. It's also about the T cell response. So we're learning a lot, and it's going to take a while to figure out exactly what's going on.
Well, actually, in some cases, immunosuppressed patients have done better. And there is a logical reason for that, is because when the virus first attacks, it's the damage that it is doing to cells. That's what causes the symptoms. But then as the attack goes on, your immune system kicks in.
True.
And you get this cytokine storm. And that is what has caused so many problems. And if you are immune compromised, you're less likely to have a cytokine storm. There's an interesting case that was reported. Actually, it was reported by Dr. Michael Greger, who is kind of an iffy creature.
Wow,
Because
I've never heard you. This is a very nice positive silver lining right now for Michael Greger and you.
I've always said that he's in the category that even, a blind squirrel sometimes finds an acorn. He's a zealot for veganism. And there's nothing wrong with that. A lot of arguments can be made for veganism, except that he tends to be very selective of literature. And anything that may be, positive in terms of dairy or meat, he will ignore. But he does have some sound science, and he reports this interesting case of a husband and wife couple, and the wife was being treated for breast cancer, so she was immune compromised. Both of them contracted COVID-19 at the same time, and she did very well, and the husband ended up in the intensive care because he suffered the cytokine storm. Now, of course, this is a single case, but it just introduces the idea that how complex this whole connection to immunity is. And that, if your immune system is compromised, in this particular case, that may not be so bad.
Yeah, I mean that's why whenever we hear about people, especially in the alternative health field, talking about boosting your immune system like it's a thermostat, I mean it is laughable. I mean, I remember learning about the immune system in university and just how mind-bogglingly complex it is, and so abstract because everything is like CD80 and CD4, CD, like all these numbers. It involves so many different types of cells and so many different types of molecules that the idea that you just boost it and then you tune it down when you don't need it, that's a complete oversimplification.
The hype, for example, about broccoli sprouts being an immune boost, and they're pushing this for COVID-19. There's nothing wrong with eating broccoli sprouts except for the taste. But besides that, there's absolutely no evidence that any single food like that is going to have an effect on the immune system.
Yeah.
Anyway, Jonathan, last time we were talking about fever and the use of the infrared thermometers and all. And there are more studies that have come out now showing that that's also an iffy thing, because there are many people who are asymptomatic who will spread the disease and who, of course, would not be picked up because they don't have a temperature. Yeah. And obviously, you can also have a temperature when you have nothing to do with COVID. But what some people now are suggesting is not to get rid of the temperature test, but to couple it with a smell sensitivity test.
Yeah, I saw that.
Yeah, because there actually is evidence that people who contract COVID will have problems with detecting smells. And it may be that this kind of anosmia presents before other kind of symptoms. So the question, though, is how do you do this? And one hypothesis is to use a relatively easily recognized smell, and that would be the smell of roses. Actually, people recognize. And although when you smell a real rose, it's a complex smell, many compounds, but the major dominant compound is phenylethyl alcohol. And if you sniff this, you'll say, yeah, that's roses. So they're thinking about having 3 test strips. One of them would have a significant amount of phenylethyl alcohol. The second one would have less, so that you have some gauge of how sensitive people are. And the third one, interestingly enough, would be a blank to test for people who would claim that they, of
course,
no sensitivity. And so anyway, this is an interesting possibility.
It is.
How would you apply this on a large scale?
Yeah, and also it's important to remind people that even that is not a specific symptom for COVID-19, because a lot of people who have the flu or have allergies will also temporarily lose the sense of smell. So it's an interesting screening criterion, but it is not specific to COVID-19.
Yeah, and I don't think it's going to be done on a large scale. It's just probably not practical to do it. There was also a paper that came out yesterday in the British Medical Journal where McGill researchers were the lead authors about the tests, serology tests, and about how these tests for antibodies really are not all that reliable. And so maybe it's you can just review for us for a moment the difference between sensitivity and specificity of a test, because that was talked about a lot here.
Yeah, I mean, it all boils down to the fact that any test, I mean, really any test, whether it's a screening test, a diagnostic test, any test will have a false positive and a false negative percentage. So just because you test positive using one of these assays does not mean that you are a true positive. And the reasons for that are many, which is that the reagents that are being used, that's part of the issue, the interpretation, all that kind of stuff goes into why we have a certain percentage of false positive, certain percentage of false negative. So what you want is for a test that has as low a percentage of false positives as possible, as low a percentage of false negatives as possible. And the other issue also, which I brought up on the stream before and in the article that I wrote about this, is the fact that the more people you test and the more rare the thing that you're testing for is in that population, the higher the percentage of false positives. So if only, 0.5% of your population has this thing that you're looking for and you're testing everybody, most of the people who will test positive, those will be false positives. And it's a bit counterintuitive, but when we start to crunch the numbers, you realize why that is. So this idea, and this is part of the reason also why the idea of mass screening people for cancer is not as great an idea as it might sound. I went through a phase when I was in grad school where this idea of like prevention against cancer is so important. Let's just screen everybody. And then I started to realize that no, actually, when you do that, you're going to get a ton of false positives. And so these people will have heightened anxiety levels. Because of that, they will need to go through more testing. They'll be more invasive. And there might be side effects to that as well. So whenever public health authorities had to decide, about, things like mammograms and prostate cancer screening, all that kind of stuff, it's not as easy as the more you do it, the better, because the more you do it, the more false positives you're going to get and the more invasive testing you're going to need. So these tests, whether it's against cancer, whether it's against COVID-19, it's very easy to think that they are the solution to everything and that the test result that you get back is 100% accurate, but that is not the case. And different tests will have different levels of accuracy. The other thing about these serological tests, as you know, Joe, is that a bunch of companies decided, hey, this is the new gold rush, and they had no experience making medical kits at all, and they just started producing them and releasing them. And the FDA in the States at the beginning were just letting them sell those kits. And so those kits were terrible in their accuracy, but they were being sold. Health Canada took a different stance. They were like, no, we're going to look at every submission very carefully before we approve them. But the FDA initially opened the doors wide open. So in the United States, you didn't know what kind of kit you were getting, how accurate it was going to be. So that's the issue with tests.
Are out there, of course, not only with this, but all kinds of dietary supplements.
Of course.
With disinfectants that actually are not effective. I mean, selling all kinds of stuff. Yeah. We talked a while ago about quercetin, which is a compound that is found naturally in numerous fruits and vegetables. It's not rare in the diet. But because there were some in vitro tests, some laboratory tests showing some efficacy against inactivating coronaviruses, of course, this got a lot of press. Well, now there are a couple of studies that are being done in Turkey where they are giving it to healthcare workers and also to some patients with no results yet. But I would be very surprised if there are any kind of positive results there, because quercetin has a very, very short lifetime in the body. It is almost immediately metabolized. So it's hard to imagine that it could be of any benefit unless, it has just the immediate effect as soon as it contacts a virus. That's very unlikely. But people are jumping on that bandwagon as well, because everyone, of course, is clutching at straws. And it's understandable, because not much is being delivered in terms of hope right?
Yeah.
And it's, as we've so often said in many contexts where science leaves a vacuum, the scammers will fill that vacuum.
Yeah. And it's not just scammers, I want to say. Like, some people are just, quote unquote, deluded in a sense. They don't understand the scientific process well enough. And so they will look at these in vitro studies and they will say, oh, well, if it worked in cells in a petri dish, it must work in a human body. But as we know, I mean, most of these early findings do not track in the human body. But it's almost a foundational pillar of alternative medicine and of bad science, of taking these early fundamental research results and then bypassing all the testing and going straight to market with those, with saying, hey, look, it worked in mice, it worked in cells, it must work in the human body. Odds are it doesn't, unfortunately.
And the number of articles out there now about masks, which are the best and how you should make, etc. I think there is, of course, agreement that now we have enough evidence that wearing masks in a situation where you are not able to distance yourself from people, that this is a good thing, and it certainly cuts down infection. And even Trump seems to be coming around to that in some way, although except for that one case backstage, when he was visiting some automobile plant, we haven't seen him wear a mask.
What did you say, Jonathan? He called himself today, wearing the mask?
What I saw in the news is that apparently Trump is now coming around to masks because they make him look like the Lone Ranger, and that's cool.
That's cool. Yeah.
Cool.
So the
President of the United States, ladies and gentlemen.
Yeah.
Which are the kind of masks? I mean, we know that the N95 masks should be reserved for healthcare workers. And of course, these are not needed by the average person. But now the surgical masks are becoming, quite readily available. You can buy them in pharmacies, etc. And this is the kind of.
I have to say they're much more comfortable. Also, they're less constricting.
Yeah. Right. And there is a difference in the studies that have been done, and whether you're wearing this or you're wearing a cloth mask that you launder, there's a couple percentage difference in these models that they use with these synthetic heads, and, they pump viruses through there. But there's another issue that arises is what happens to these, because many of them, of course, are disposable. These are disposable, and you see them on the street now. You see them lying everywhere. You see gloves lying everywhere. Okay, well, what happens to them? There's a layer of propylene in these, and polypropylene is a plastic. And of course, there's issues about plastic in the environment and about microplastics. We had a study that came out this week. They found microplastics, meaning these are little bits of plastic that are only viewable through a microscope, sometimes not even a microscope, but through an electron microscope. And they found them in apples, they found them in carrots, and a large variety of other fruits and vegetables. Now, this, of course, alarms a lot of people that you have these microplastics in food. And nobody really knows what to make of these at this point. Plastic in general is inert. Chances are that this goes right through your body and comes out the other end. But maybe there are some chemicals, some toxins that stick to the surface of these tiny little beads and stay in the body. Nobody knows. Okay, but when you're looking at these masks and they get discarded in the environment, they will eventually break down. And they will be a source of microplastics. And when you're talking about populations, global populations using these, you're talking about a lot of plastic that is being discarded. So some people are arguing for the cloth masks. Of course, that those are environmentally much more friendly because you can launder them. And the fact is that there probably is not a whole lot of difference in terms of if done properly. We know that they will prevent the large droplets from being expelled by the wearer. They are less effective at allowing smaller droplets to come through from someone else, but it is still worthwhile. But here's an interesting story that who could have ever predicted that we would be worrying about the plastic that is being discarded by these masks?
It looks, I mean, when you see them on the street and the gloves, it looks like a horror movie. I mean, that's it. Yeah, it looks like we're on a film set or something.
It is. And, there's the question of, do you put them in the recycling bin or do you put them into the garbage?
Yeah. Well, can you talk, so some face masks now are being sold with copper inside, right? Or lining them. Yeah. So what is that about?
Well, copper is very interesting because we know that it has disinfectant properties. Viruses and bacteria that land on a copper surface will eventually be deactivated. But the word eventually is a key word here. This is not an immediate effect. A study published in New England Journal a few weeks ago that we talked about, where they looked at different surfaces and found that on a copper surface it lasts about 4 hours, on a plastic or metal surface it can last days. So yes, it lasts a shorter time on a copper surface, but we're still talking about hours that are needed for deactivation. So when you have copper in a mask, any virus that lands on the surface of the mask and stays on the surface of the mask will eventually be inactivated by the copper in the mask. But the copper does not prevent virus from going through the mask. It makes the mask more reusable because, you take off the mask, if there's any virus on the surface, that will be deactivated by the copper. So next time that you put it on, it's not there. What I think is more interesting are copper surfaces in hospitals, because their studies have really shown that when you have a thin coating of copper on doorknobs, on the trays that they roll over the bed, on the bed itself, because hospital-acquired infections are very, very common, both viral and bacterial. And where you have copper surfaces, there's no question that there are fewer of these infections. So I think there can be a movement to introduce more copper into hospitals. But with the copper masks, I think also should point out that the manufacturers will tell you that they have done some studies on the inactivation of the virus on copper, but they will not claim any benefit for COVID-19 because nobody has shown that fewer viral particles pass through those kind of masks. But in storage, yes, there will be some disinfection on these, but they're also charging a lot of money. Mm-hmm. It's $50 to $70 for these masks.
Oh my gosh! Wow.
Yeah, and I don't think that anyone's demonstrated the benefits there.
Can we go to Facebook? We have a couple questions on Facebook. One, we were talking about Pfizer being the company and the vaccines that what we were just saying, but do we foresee any antiviral medications that they would be developed before a vaccine? I mean, have any companies been talking about that? Maybe that is a more probable route or quicker solution?
There are a lot of these antivirals that are being looked at. Remdesivir is the one that we've discussed here, which has shown some efficacy in reducing number of days spent in a hospital by someone who's seriously affected. And of course, this is a big deal for hospitals. If you can cut down the hospitalization for 15 days to 11 days, that's a big deal. But it has not had an effect on mortality. So people who were treated with remdesivir are not any less likely to die. But if they survive, then they will spend fewer days in the hospital. And then, of course, we had the whole hydroxychloroquine story, which mercifully now is kind of vanishing because there isn't any evidence for it. But there are a lot of other antivirals which are in the same family as remdesivir that are being researched. And the hope is that eventually something will come out of here, I think probably before a vaccine.
We'll have to see. Yeah, we'll have to see because antivirals are notoriously difficult I mean, it's difficult to find antivirals that have a good efficacy. I mean, I think something like over half of the antivirals on the market right now are for HIV. So we've been very successful discovering and synthesizing antivirals against HIV. For the rest, I mean, there have been a lot of tests and not a lot of good stuff that's come out of that particular pipeline. So it's a particularly challenging type of medication to develop.
What other question was there?
So one, just circling back to the masks quickly, but there is something else I want to ask about heat, like heat in the car. If you keep a face mask in the car, does heat impact them? Like me too, I'm also taking them off. I'm leaving them in the car.
The question of time. The usual kind of temperature that is quoted for guaranteed disinfection is 70 degrees. You're not likely to get that in the car. But we also know that even at ambient temperatures, the virus gets inactivated with time. So that's why, if you have a paper bag and you put your mask in there and you rotate a few masks and, you leave them in that bag for 2-3 days, chances are that there's no virus left on there.
I've started hand washing mine also. Instead of just like tossing them in the laundry, I just hand wash them with soap and hot water and then hang them to dry, kind of thing. Yeah.
Yet another skill that Emily has.
Yeah, there you go. Although I'm only washing the masks in my household, I'm not offering that to others. We have another question here about swimming pools and outdoor pools. Often, though, if you go to a community center or gym, you still have to walk through the gym to get to the pool. And masks are not mandatory unless if you're greater than 6 feet. So as people are walking quickly to the pool, is that okay? What about pools? Chlorine, distance in a pool if you're swimming laps? Yeah.
Okay, let's get back to something that we've talked about several times here before, both in terms of toxicology and virology. And that is that risk is a product of hazard and exposure. Hazard is an innate property of matter, and you cannot change it. The classic example that I always give, and people are probably sick of me giving this example, is a grizzly bear. We know that a grizzly bear is a hazard, but if you see it in a zoo, you're not worried. The hazard is still there. If you see it out in the wild, you better start running fast, right? Because there your risk has increased. So the risks are different, even though the hazard is the same. It's exposure that matters. There's no question that the virus that causes COVID-19 is a hazard, right? Nobody debates that. But the question is, how much of it do you have to be exposed to and for how long? And of course, there are uncertainties there. But I think just walking through a room is very unlikely. However, if you sit in a room where you have 100-person choir singing at you and expelling their sputum, like we saw the other night where Pence was in the path of that, that's a different story. So I wouldn't worry all that much about walking through a room. And when you get to the pool, well, the same distancing rules hold there. The water doesn't matter. The virus is not transmitted in the water. But you don't want to be playing in the water with someone who's breathing on you. Although chances outdoors are still less than indoors. Interestingly enough, with all of the demonstrations that we saw a couple of weeks ago in the US and all the talk that is what would cause the spikes. It turns out that now when they do the contact tracing, there are huge spikes in the US, of course, but they're not being traced to the demonstrations. They're being traced to opening of bars and restaurants and people organizing indoor activities.
So why do you think why is that? Because it was outside and people, not everyone was wearing a mask in those demonstrations.
It's the air currents and the winds. I think if you were to map what comes out of your mouth, the dilution effect outdoors is far greater than it is indoors. And of course, it's gone, right? Outdoors, it will, I shouldn't say gone, but it gets diluted. Whereas indoors, it keeps being recirculated. You're breathing the same kind of air. That's why I really don't worry that much about outdoors. I think when you're walking outdoors, you don't need to wear a mask unless you're walking in a closed group. And if you're bicycling, I don't think to wear a mask. I think it's probably not a good idea now to be bicycling in a peloton where you're bicycling with 100 people all together, because the people in front of you, of course, are exhaling, and if you're riding along, you'll be inhaling that constantly.
Yeah.
But
A lot of solo activities this summer.
a lot of solo activities. Yes.
Yeah. We have actually a question from Ross, who also works in the chemistry building at McGill. He says he's still seeing recent articles on the role of nitric oxide in COVID-19. Have you read anything about that? I think it also came up on a previous webcast.
Right. Nitric oxide is a vasodilator. Nitric oxide is the secret behind Viagra, right? And so anytime that you can benefit from vasodilation, from dilation of arteries, nitric oxide plays a role there. Now, as again we've talked about, one of the consequences of COVID-19 infection is the synthesis of microthrombi, of very small blood clots. And these can wind up anywhere in the body. Well, obviously, if you dilate the blood vessels, you're less likely to form blood clots. You're less likely that the microthrombi are going to coalesce into a blood clot that can block the flow of blood. That's the theory. No one has done any investigation to see whether or not people who constantly use Viagra are less likely to get COVID-19. There's a stimulus for someone
There would be an interesting study. That would be interesting. Yeah.
And sometimes the same argument is made for a dietary supplement called arginine, because arginine is a precursor to nitric oxide. So here, this is one of those things which does have some theoretical possibility, but it would need some very serious investigation, and it would not be easy to investigate this. But I would not bet on it.
We have two questions actually. So in Montreal and Quebec, there is no mandatory mask law, although there are specific boroughs who they can do what they want, and Côte Saint Luc is one of them, which, Joe, you are familiar with. So in Côte Saint Luc, you have to wear a mask anywhere you go indoor, right? So should Montreal follow Côte Saint Luc's policy, and should Quebec? Yeah.
I think there's enough evidence now that wearing a mask indoors will cut down. And especially, when you're going shopping where there are a lot of people in the same store. And plus, what's the downside? What's the downside? And if there's something that we can do that may have some benefit, why not do it? If it turns out, after a few months that there's no difference, well, then we will have learned that. But I think right now there is not overwhelming evidence, but there is enough evidence to suggest that wearing a mask indoors where people congregate is a good idea, and you get used to it. I go onto IGA, I put on a mask. It doesn't interfere with anything, and in the U.S. there's this idea that masks are somehow political, and that either by wearing or not wearing a mask you're making a political statement. Is just ridiculous.
I don't know. I don't know, Jonathan, if you've seen it. Tory Burch. There's a new like the fashion company. It's the hashtag wear a damn mask, and all the celebrities are just posting like wear a damn mask, and they do like a little blurb before, because it's not a political statement. It literally is like a human. I mean, it's like an ethical. I mean, this is for everyone basically. And as Legault said, it's a respect for other people at this point.
Yeah, I mean, I am worried about people who have claustrophobia, some people who have touch-related issues, some people with autism, for example. So I'm always worried when we're saying, we're going to be enforcing this, everybody needs to do this. There are people whom I don't think really can do it. So how do you deal with that? I'm not sure. You might have seen online there are people, though, in the States who don't have these issues, but who are manufacturing fake cards allegedly related to the ADA, which is the American with Disabilities Act, saying that they have been cleared to not have to wear a mask, and those things are false. They're not real. So there's all of that, right? Whenever you're enforcing something for the whole population, you have to think about these things. So it's not an easy decision to make.
Well, sorry, Joe.
Everything gets more complicated when you scratch the surface. Everything,
Yep.
right?
Yep.
That's a given. But there was this video going around from Florida where they did make it obligatory in some counties to wear a mask, and the venomous attack against this in these public hearings, unbelievable. There was this one woman who was so outraged and was attacking a doctor who was making a case for this, saying that she's going to make a citizen's arrest because he should be in jail. Then the other lady was saying, God gave us the right to breathe. Who is man to take away that right? I mean, some of these just...
I think I saw that. It was in Florida, you said?
In Florida.
I actually saw it, and it got me very upset. Like, to me, it's comical, but then it's infuriating because it's for real. It's hard to look away, but I want to look away.
There was somebody on Twitter who said that we're going to have to retire the plague. We're going to have to retire the phrase "avoiding it like the plague" because it turns out that we're not very good at avoiding it. And that's the thing. Like we're in the middle of a kind of a plague, and we're seeing that so many people just don't care for this, and they don't care about the measures that we have to take in order to get this under control. It's a fascinating sociological experiment, except that our lives are at stake.
Well, someone on the stream just said one of the people in Florida, because she's in Florida, they took a lawyer and they're going to present this in front of a judge.
Yeah.
Yeah.
Well, this is the U.S. and it's just so fascinating to watch what is going on in that country. We're seeing more and more young people between the ages of 20 and 40 infected, and young people are not immune as they think that they are, and so when you look at the numbers in the U.S. and you look at the graph, it's just absolutely stunning. So it's not surprising that the European Union has said that they will not allow American passports to enter, and we'll see what that does politically in the U.S. because Trump is not going to be happy with that one.
Yeah.
Oh, I have a good. We're kind of nearing maybe the end of our session, but we've another one. So some of my friends are playing Mahjong outside with masks. Is that okay? Is it? Would that be allowed? Do you think that would be advised? I mean, I have my own opinion, but.
This question has come up not only with Mahjong, which I don't know how that game works except that you use tiles.
It's very serious for some people.
Yes. The question has come up about that and also about cards, which is, I guess, more relevant. People play a lot of cards. I think it's a time to once again point out that the chance of transmission by touching something is very, very low. It has to be a really unique circumstance where someone has deposited the virus relatively recently on that surface. You touch it, and then you touch your face. If you are playing with cards and nobody touches their face, there's no chance of infection. There's very little chance in any case because the survival of virus on cards in infective amounts is very unlikely. So I think the benefits of playing Mahjong or Go or cards and having some social interaction outweigh the detriments. Of course, the question is where you're doing the playing. If you're playing cards indoors, you are generally within 6 feet of the people that you're playing with. That's quite a different story from playing Mahjong outdoors. So,
Joe, business opportunity for you: a set of cards made out of copper.
Look at that. Oh, he's looking. Maybe.
Do you have a deck?
Funny that you should ask.
Really?
It's actually not copper. It's gold.
It's gold.
Okay.
And gold also has the same property as copper.
Right.
Silver and copper are in the same family. And all of these have the ability to destroy the virus on their surface.
Are they made entirely out of gold, or they're just infused with gold threads?
It's a very thin layer of gold,
Okay.
because gold is extremely, extremely malleable,
Mhm.
which means that, actually you with the size of half a small matchbox, you could pound that into the size of a tennis court. So,
Oh, wow.
yeah. So, here.
You're going to be getting
Pick a
offered
card.
a lot of money on that.
The gold on here is such a thin layer that financially, of course, I can't make it. But at least it is interesting. But yeah, you raise an interesting business
Yeah.
opportunity there. Copper coated or gold coated cards.
There we go.
Here, pick a card. That's the one you picked?
Yeah.
Yeah. You know what it is? Let me guess. The 4 of diamonds, right?
Right.
Well,
Right.
Right.
That was a great trick.
great trick. Great trick.
With that great trick, I guess we've come to the end.
Yeah.
We'll say goodbye. And Emily, what do we have coming up?
Yeah, we'll be back next Thursday at 12. Jonathan won't be here, but Professor Tim Caulfield will be. We're very excited to speak with him. He has some new CIHR research happening all about, again, how to combat fake news and misinformation in this COVID era. And it's always fun to speak with Tim. So we'll be back next Thursday at noon, 12 Eastern.
Okay. And maybe by then I'll do a real trick.
Sounds good. Okay. Bye,
All right,
everyone.
so I will hold cards.
Bye.
Thank you. Bye.